Congenital heart disease. Asynotic congenital heart disease, left to right shunt lesions, which will be the atrial septal defect, ventricular septal defect, atrioventricular septal defect, and the patent ductus arteriosus. Atrial septal defect. This is the opening of the atrial septum, permitting the free communication of the blood between the atria, seen in the 10% of the all CHD. There are three major types. Secondum ASD at the fossa ovalis, most common. Primum ASD, lower in the portion, and is a form of ASVD, MV cleft, sinus venosus, high in the atrial septum, associated with the partial anomalous venous return and the left common. Atrial septal defect secondum ASD, sinus venous ASD. Atrial septal defect, the clinical signs and symptoms. They are rarely present with the signs of CHF or other cardiovascular symptoms. Most are asymptomatic but may have the easy fatigability or mild growth failure. Cyanosis does not occur unless a pulmonary hypertension is present. Atrial septal defect, the clinical signs and symptoms also have the hyperactive precordium, RV heave, fixed widely split S2, 2, 3, 6 systolic ejection murmur LSB, mid systolic murmur lead to the over LLSB. What causes the systolic and the diastolic murmurs of the ASD? Caused by the increased flow across a pulmonary wave, not the ASD in the systolic murmur, while the diastolic murmur is caused by the increased flow across the tricuspid wave. This suggests the high flow of QPQS 2:1. Treatment. The surgical or the catheterization laboratory closure is generally recommended for the secondum. For ASD, QPQS ratio greater than 2:1. Closure is performed electively between the ages 2 and 5 years to avoid the late complication. The surgical correction is done earlier in the children CHF for the significant pulp HTN. Atrial septal defect treatment. Once the pulmonary hypertension is with the shunt reversal occurs, this is considered too late. Mortality is lesser than 1%. Is endocarditis prophylaxis required for the ASD? No. Ventricular septal defect. This is the abnormal opening in the ventricular septum which allows a free communication between the RT and LT ventricles. Accounts for 25% of the CHD. Types. Perimembranous or membranous, most common. Infundibular, subpulmonary or the supracranial VSD involves the RV outflow tract. Muscular VSD can be the single or the multiple. AVSD, inlet VSD, almost always involves AV valve abnormalities. Hemodynamic, the left to the right shunt occurs secondary to the PVR, being the lesser than SVR, not the higher pressure in the LV. This leads to the elevated RV and the pulmonary pressure and the volume hypertrophy of the LE and LV. Clinical signs and symptoms. Small, moderate VSD, 3 to 6 mm are usually asymptomatic and the 50% will close spontaneously by age 2 years. Moderate, large VSD almost always have the symptoms and will require the surgical PAP. 2 to 3 V or 6. Harsh holosystolic murmur heard along the LSB, more prominent with the small VSD, may absent with the very large VSD, prominent P2 diastolic murmur. CHF respiratory infection, excess intolerance, hyperactive precordium, systems develop between the 1 to 6 months. Treatment. Small VSD, no surgical intervention, no physical restrictions, just reassurance and the periodic follow-up and the endocarditis prophylaxis. Symptomatic VSD, the medical treatment initially with the afterload reducers and the diuretics. Indications for the surgical closure. Large VSD, medically uncontrolled symptomatology and the continued FTT. Ages will be nearly 6 to 12 months with the large VSD and the pulmonary hypertension. Age greater than 24 months. QPQS ratio is greater than 2:1. Supracustal VSD of any size secondary to the risk of developing AV insufficiency. AVSD results from the incomplete fusion of the endocardial cushions which help to form the lower portion of the atrial septum, the membranous portion of the ventricular septum, and the septal leaflets of the tricuspid and the mitral waves. They account for nearly 4% of all CHD. Complete form. Low primum ASD continues with the posterior VSD, cleft in both leaflets of TV or MB. results in the large L of the R shunt at both level, TR or MR pulmonary hypertension with increased PVR. Incomplete form, any one of the components may be present. Most common in the premium ASD, cleft in the MV and the small VSD. Hemodynamics are dependent on the lesion. Atrioventricular septal defect, complete AVSD. The clinical symptoms incomplete AVSD may be the indistinguishable from the ASD, usually symptomatic. Congestive heart failure is in infancy, recurrent pulmonary infection, failure to thrive, excess intolerance, easy fatigability, late sinus freeze from the pulmonary vascular disease and R2L shunt. Clinical signs and symptoms also have the hyperactive precordium, normal or the accented first heart sound, wide fixed splitting of the S2, pulmonary systolic ejection murmur with thrill, hollow systolic murmur with the apex radiation to axilla, with diastolic rumbling murmur, LSB, marked cardiac enlargement on the CXT. Treatment, the surgery is always required. Treat the congestive symptoms. The pulmonary banding may be required in the premature infants or the infants with less than 5 kg. Correction is done during the infancy to avoid the irreversible pulmonary vascular disease. Mortality low with the incomplete 1 to 2% as high as 5% of the complete AVSD. Patent ductus arteriosus. This is the persistence of the normal fetal vessel that joins the PA to the aorta, normally closes in the first week of life, accounts for 10% of all CHD, seen in the 10% of the other congenital heart lesions, and can often play a critical role in some lesions. The female-male ratio will be the 2:1, often associated with the coaction of a VSD. Hemodynamics. As a result of higher aortic pressure, the blood shunts like L to R through the ductus from aorta to the PA. Extent of the shunt depends on the size of the ductus of the PVR and SVR. Small PDA, there will be the pressure in the PA, RB and RA are normal. Large PDA, RA pressures are equal to the systemic pressure. In the extreme cases, 70% of the CO is shunted through the ductus to the pulmonary circulation, leads to the increased pulmonary vascular disease. Clinical signs and symptoms like a small PDA are usually asymptomatic. Large PDA can result in the symptoms of CHF, growth restriction and FTD, bounding arterial pulses, wide pulse pressure, enlarged heart, prominent apical impulse, classic continuous missionary systolic murmur with diastolic murmur at the apex. Treatment, indomethacin, inhibitor of the prostaglandin synthesis, can be used in the premature infants. PDA requires a surgical or the catheter closure. Closure is required for treatment for the heart failure and to prevent the pulmonary vascular disease, usually done by the ligation and the division of the intravascular coil. Mortality is less than 1%. Obstructive heart lesions, there will be the pulmonary stenosis, aortic stenosis and the coaction of the aorta. Pulmonary stenosis, this is obstruction in the region of either the pulmonary vein or the subpulmonary ventricle outflow tract, occurring for nearly 7 to 10% of all CHD. Most cases of the isolated lesion may be bicuspid or the fusion of the two or more leaflets, can present with or without the intact ventricular septum. Hemodynamics will be the RV pressure hypertrophy, RV failure. RV pressure may be systemic failure, post-stenotic dilation of the main PA, intact septum and the severe stenosis or L shunt through PFO cyanosis. Cyanosis is indicated of the critical PS. Clinical signs and symptoms depends on the severity of obstruction. Asymptomatic with the mild PS is lesser than 30 mg, moderate or severe 30 to 60 mm Hg or greater than 60 mm Hg. Prominent jugular A wave, RV lift, split second heart sound a delay, ejection click followed by the systolic murmur, heart failure, cyanosis seen in the severe cases. Treatment will be the mild PS, no intervention required, close follow-up. Moderate to severe require the relief of stenosis. Balloon valvoplasty treatment of choice. Surgical valvotomy is also the consideration. Aortic stenosis, this is the obstruction of the outflow from the left ventricle or near the aortic wave that causes the systolic pressure gradient of more than 10 mm Hg, accounts for 7% of the CHD. 3 types: valvular, most common; subvalvular, subaortic, involves the left outflow tract; supravalvular, involves the ascending aorta, is the least common. Hemodynamics, pressure hypertrophy of the LV and LA with obstruction to flow from the LV. Mild AS 0 to 25 mm Hg, moderate 25 to 50 mmHg, CVA is 50 to 75 mmHg, critical AS greater than 75 mmHg. Mild AS may be present with excess intolerance, easy fatigability, but usually asymptomatic. Moderate AS, chest pain, dyspnea on the exertion, dizziness and the syncope. Severe AS, weak pulses, left-sided heart failure, sudden death. Clinical signs and symptoms like LV thrust at the apex, systolic thrill, at RT base, supraspinal notch, ejection click, 3 to 4, 6 systolic murmur, RSP, LSP, radiation to the carotids. Treatment may because the surgery does not offer a cure, it is reserved for patients with symptoms and the resting gradient of 60 to 80 mmHg. For the subaortic stenosis, it is reserved for the gradients of 40 to 50 mmHg because if it's rapidly progressive mature balloon valvoplasty, this is the standard of treatment for aortic stenosis. Aortic insufficiency at the restenosis is likely after the surgery, may require the valve replacement. Activity should not be restricted in mild AS. Moderate severe aortic stenosis, no competitive sports. Coaction of the heart is narrowing of the aorta at the varying points anywhere from the transverse arch to the iliac bifurcation. 98% of the coaction on the juxtaductal male-female ratio is 3:1, accounts for 7% of all CHD. Hemodynamics, the obstruction of the left ventricular outflow will be the pressure hypertrophy of the LV. Classic signs of the coaction or the dimension or the absence of the femoral pulses. Higher BP in the upper extremities or compared to the lower extremities. 90% of the systolic hypertension of the upper extremities. Pulse discrepancy between the RT and IT arms. Clinical signs and symptoms also have the severe coaction, early hyperperfusion, acidosis, HF and shock, differential cyanosis if ductus is still open, second and the sixth systolic ejection murmur, LSB, cardiomegaly, rib notching on the X-ray. Treatment will be with the severe coaction, maintaining the ductus with the prostaglandin E is essential. Surgical intervention to prevent the LV dysfunction. Angioplasty is used by some centers. Recoaction can occur. Balloon angioplasty is a procedure of choice. For anatomic malformation, right ventricular hypertrophy, pulmonary wave stenosis, transposition of the aorta, ventricular septal defect. TOF, RVH, secondary to PS stenosis, increased P on RV leads to RVH, transposition of the aorta, aorta is displaced. VST, hole in the heart, mixing of the oxygenated and the unoxygenated blood, cyanosis. PVS, more severe, less blood transported to the lungs and more deoxygenated blood will pass through the VST to the aorta to be circulated through the body. Etiology, the theory will be the destruction of the neuronectus cells during the embryogenesis in the laboratory settings. Destruction of those cells reproduced results that displayed with a certain cardiac malformation. Clinical presentation is directly related to the degree of pulmonary stenosis. Severe stenosis results in the immediate cyanosis following the birth. Mild stenosis will not present until the later. Growth is retarded, insufficient oxygen and nutrients, SOB and exertion. Death spell, at 2 to 3 years old, child becomes cyanotic, may experience a syncope. Exams and tests will be CBC hematocrit, ECG, RVH and radiograph. CXR, boot-shaped heart, right-sided aortic arch, echocardiogram, VSD. Surgical intervention 1, complete intercardial repair of the VSD and PS stenosis. Enter the chest through the sternum, connect the heart and the lung machine. Heart is stopped, repair the VSD with a patch. Determine if PA needs to be removed or if removing the excessive muscle tissue will help to function correctly. Pacemaker wires are placed temporarily because of the potential for the post-operative ventricular arrhythmia. Individual chamber pressures are then measured before the chest is closed. The pressure readings help to determine how effective the surgery was. Complications will be ineffective bacterial endocarditis, pulmonary regurgitation, arrhythmia, RBB, or the left anterior hemiblock. Thank you.